than 1 curie, that is more than 1000 milli. So, and the patients who are receiving multiple cycles, they also have a minimal chance of secondary malignancy. Most common is being the hematological malignancy. TSH suppression post RA. So how the TSH suppression target for low risk patient is between 0.5 to 2. For intermediate risk, we keep between 0.1 to 0.5. For high risk patients, we keep the TSH target less than 0.1. So what is the first follow-up will be at 6 months. So at 6 months, we ask the patient to stop L-troxin and start iodine restricted diet for 1 month. Once the TSH goes more than 30, we do a stimulated thyroglobulin, serum thyroglobulin. And also we look for anti-TG, because when anti-TG is raised, then serum thyroglobulin level becomes unreliable. So it is mandatory to see anti-TG also. Then if the TG level is elevated, then we do a whole body radioactive iodine scan, that is give up to a dose of 3 millicurie, and we do a whole body scan, and we do an ultrasound neck also. Now the patient undergoes dynamic risk stratification. So what are the components of dynamic stratification? The first one is excellent response. The second one is biochemically incomplete response. Third one is structurally incomplete. And the fourth one is indeterminate response. What is excellent response? So at 6 months post RA, the stimulated thyroglobulin is less than 1 nanogram per ml, or the unstimulated thyroglobulin is less than 0.2 nanogram per ml, and the USG and the radioactive iodine scan are normal. So these patients fall into the category of excellent response. So what is biochemical incomplete response? When the stimulated TG is more than 10 nanogram per ml, or the unstimulated TG is more than 1 nanogram per ml with a normal RA imaging. This patient goes into the biochemical incomplete response. And then structural incomplete response, those patients who have an evidence of structural disease on imaging, regardless of the thyroglobulin level. So indeterminate, who goes into the indeterminate response? The patients who have a non-specific or inconclusive findings with a TG level which falls between 1 to 10, stimulated TG which falls between 1 to 10 goes into this indeterminate response. So what are the management? How we manage according to the dynamic stratification? When the patient is under the excellent response criteria, the TSH suppression will change to 0.5 to 2. When the patient is under biochemical incomplete response, we repeat TG after 3 months. If it is still high or rising further investigations like RA imaging or FDG PET CT is recommended. For the TSH suppression should be 0.1 to 0.5. For structurally incomplete response patients, we have to treat the structural disease with a TSH suppression of less than 0.1. For indeterminate response, we keep the patient on TSH suppression like 0.1 to 0.5. After 6 months, we repeat the TG, and most of the time, the indeterminate category patient will convert into excellent response. That is, if for the indeterminate, the TG value will be between, stimulated TG is between 1 to 10. If we see after 6 months, mostly it goes below less than 1, that is into the excellent response category. So what are the adverse effects of long-term TSH suppression? So since we put all these patients under long-term TSH suppression, the most common side effect is subclinical thyrotoxicosis, increased risk of atrial fibrillation, increased risk of osteoporosis, and exacerbation of angina in patients with known ischemic heart disease. So this is the picture from the ATA. So this gives us an idea about how to keep the TSH suppression in different dynamic risk category, and along with what are the factors which we take into consideration before deciding the TSH target. Like if there is a female is a postmenopausal woman, if the patient is having a osteopenia and the age is more than 60, osteoporosis or atrial fibrillation, these are the risk factors which we should consider before deciding the TSH target for the particular risk category. So moving on to the administration of radioactive iodine. So how we prepare the patient? So we ask the patient to stay off L-troxin. If the patient is taking T4, then they should stay off minimum 4 weeks. The patient is on T3, minimum of 2 weeks, they should abstain from taking T3. Those patients who cannot tolerate thyroid withdrawal, we can use recombinant TSH. The dose is 0.9 milligrams subcutaneous injection on 2 consecutive days. And the third day, we can give the radioactive iodine. The only drawback is the cost of recombinant TSH, because it almost costs 1 lakh if you, per dose, the 2 doses. That is the only drawback for this recombinant TSH. Otherwise, both the methods of recombinant TSH and the T4 withdrawal of thyroid stimulation is sensitive enough. Iodine restriction, minimum of 2 weeks is needed. 2 to 4 weeks, 4 weeks is ideal. And then intravenous contrast should not be given in the previous 4 weeks. Patient should avoid seafood, iodine-containing drugs, and iodized table salt. And complete the basic blood workup we have to do. And then in case of pregnant women, we should rule out pregnancy before giving radioactive iodine. So what the TSH should be more than 30, and the patients who require a dose of more than 30 millicurie they need to be admitted to the specialized radioactive isolation ward. What the pre-medications? So before giving radioactive iodine, we give proton inhibitors, and then also advise laxatives. And then those patients who had brain meds, or those patients who had spinal meds with impending cord compression, we start a steroid cover. After the patient administering radioactive iodine, the patient will be kept in the isolation ward till the radiation level comes below the acceptable limit. That is, if the patient's radiation level comes below less than 5 mR per hour at a distance of 1 meter, at that time we will discharge the patient. So what are the radiation safety aspects? So since this radioactive iodine, sodium iodide, is volatile, it is available in liquid form. The higher doses are available in liquid form. So this is kept inside a negative pressure fume hood. And the patient is counseled to follow strict radiation safety precautions during the therapy. And when the patient is admitted in the ward, they have to follow certain safety precautions, and they have to follow those precautions up to 2 to 3 weeks after the discharge. So what is RA refractory DTC? So the first criteria which is considered as RA refractory is the malignant metastatic tissue does not ever concentrate radioactive iodine. That is, no uptake outside the thyroid bed at the first post-therapeutic whole body scan. The second scenario is the tumor tissue loses the ability to concentrate RA after previous evidence of RA-avid disease. The third scenario is RA is concentrated in some lesions but not in others. Fourth one is metastatic disease progresses despite significant concentration of radioactive iodine. How to manage this RA refractory DTC? First, we have to determine the extent of metastatic disease by imaging studies, then assess the degree of potential symptoms from the particular disease, and understand the comorbidities that might influence the choice of therapies, and determine the rate of progression of radiographically evident lesions. The treatment options include stereotactic radiation, thermal ablation, TKIs, and bone-directed agents. Tennis. What is tennis? So this can happen in around 2 to 13% of patients. First thing we have to rule out is iodine interference, because tennis is thyroglobulin elevated negative iodine imaging. So whenever we follow up a patient and if we find the TG is elevated, and if we do a radioactive iodine scan, and if you are not seeing anything in the scan, so this is called as tennis, thyroglobulin elevated negative iodine imaging. The first thing we have to rule out is iodine interference. We have to take a clear history from the patient to rule out iodine interference. To confirm the iodine interference, we can even look for the urinary iodine clearance. So by this way, we can rule out iodine interference. The second one is the iodine 131, which we use in India. It is of an inferior image quality over the I-123, which the Western countries use. So that we have to make sure we have given adequate dose of I-131 and the imaging parameters are good enough to acquire a clear image. Sometimes it could be due to the tumor dedifferentiation, where the tumor cells lose the ability to concentrate the radioactive iodine. So, how to evaluate tennis? First, we have to do an ultrasound neck, and if the disease is located, we should see whether the disease can be operated or whether it is inoperable. If the disease is inoperable, then we can consider empirical dose of radioactive iodine, EBRT, TKI, and PRRT, redifferentiation therapy, and chemotherapy. If the disease is if we are not able to locate the disease, we can do an FDG PET CT. Same, if the disease is located, then we can do a directed treatment according to the site of the disease. If the disease could not be located, we can observe with TSH suppression. So what is the role of empirical radioactive iodine? So empirical radioactive iodine means when we do a 3 millicurie radioactive iodine scan, if we are not seeing any kind of iodine concentrating lesion in the body, but still the thyroglobulin is elevated, so we can give an empirical higher dose of RA. Sometimes the 3 millicurie dose which we use for a diagnostic whole body scan may not be adequate to map the disease. So at that condition, we can give a higher dose, empirical treatment dose. It is for both the disease localization and for the non-surgical candidates. So it is useful in patients with the serum thyroglobulin of more than 10. The dose of 100 to 200 millicurie is used. If the post-therapy imaging is also negative, no further RAE is recommended in these patients. If post-therapy thyroglobulin shows decreasing trend, then this patient will have a better survival. So these are few images to show. So this is a low risk patient. This left-sided image is the 3 millicurie whole body diagnostic imaging. So this shows a focal tracer uptake in the thyroid bed. And this patient has been administered with 30 millicurie of radioactive iodine for remnant ablation. And the right side one image is the post-therapy image. So this is the diagnostic 3 millicurie whole body scan, and this is the post-therapy image, and this is the SPECT CT has been acquired. This image also you can see the post-therapy scan. The bed remnant has taken up the radioactive iodine, and in the cross-sectional SPECT CT you can clearly see there is a ill-defined soft tissue in the left thyroid bed which is concentrating the radioactive iodine. So after giving this radioactive iodine for a low risk patient, we start Eltroxin on the next day itself. So we start a higher dose to keep the TSH suppressed. So for a low risk category, we maintain a TSH target of 0.5 to 2. After 5 months, we ask the patient to stop Eltroxin and restart iodine restricted diet. After 1 month of following these precautions, we do a serum thyroglobulin, that is stimulated thyroglobulin, with an ultrasound neck. So if the serum thyroglobulin and ultrasound neck is negative, then there is no need for a whole body scan in low risk patients. So this is, but we have, for this patient, the serum thyroglobulin was a bit raised. So we did the diagnostic whole body scan after 6 months. So here we can see the remnant on the left thyroid bed, which is completely gone in the 6 month scan. So this patient goes into an excellent response. Though the serum thyroglobulin is mildly elevated, this goes into not the excellent, the indeterminate response actually. This is second patient. This is a patient, intermediate risk patient, who had a extensive local extrathyroidal extension with a tracheal infiltration. This is the this is the 3 millicurie imaging which we have done. We show a focal uptake in the thyroid bed, and this is the SPECT CT. We can see the left thyroid bed. We can see a focal uptake. This patient has been administered with 100 millicurie of radioactive iodine, since there is a gross extrathyroidal extension and tracheal infiltration. After 6 months, the stimulated TG was 5.4, with anti-TG was less than 5.9, and the USG also negative. And the 3 millicurie scan, that neck uptake is completely gone. So this also goes into an indeterminate response. So in this kind of patients, we follow up after 6 months again with stimulated thyroglobulin. Mostly it goes below 1, that is the excellent response category. So this is another patient. This is the post-treatment scan. Actually, this patient, even in the pre-surgery workup, this patient was identified with lung nodules actually. So this patient, after the surgery, this patient was administered with 200 millicurie of radioactive iodine, and this is the post-therapy scan. In the post-therapy scan, we can see multiple neck nodes which are there in the here level, I think pre-tracheal and pre-laryngeal region, and both the lungs are showing extensive tracer uptake. Very tiny nodules which you may not appreciate in one particular section. So this called as like micrometastasis. Though this is a phenomenon called micrometastasis in thyroid, where the entire both the lungs will show diffuse radioactive iodine uptake. So this is another patient who had an extensive skeletal metastasis. So these patients received 200 millicurie of radioactive iodine. So, what are the precautions we advise for the patients after the radioactive iodine? So, when the patient is admitted in the ward, we ask the patient to keep well hydrated. Because predominantly the most of the radioactive iodine which we administer is excreted through the urine. So we ask the patient to keep well hydrated, and then we ask them to take sour candies or lemon continuously every half an hour, because the radioactive iodine which we administer predominantly is excreted through the salivary glands. So to prevent the salivary gland ablation, we ask the patient to take sour candies or lemon extract every half an hour, and then we ask them to drink plenty of water. And after using the washrooms, we ask them to flush it with plenty of water. These are the precautions which they follow when they are admitted inside the ward. Once the radiation level goes below 5 mR per hour, these patients are discharged, and after the post therapy scan, we allow the patient to go home. So, what are the precautions we advise them to follow at their home? So we usually advise them to stay off in a separate room, and if the patient can have an access to a separate toilet, it is better. If there is no access to a separate toilet, then after using the toilet, they should use plenty of 2 to 3 buckets of water to flush the toilet, and they should keep their clothes separately, and it should be washed separately, and they should not cook. You should not indulge in cooking, because this radioactive iron is excreted through the sweat also. So even the palm, it is excreted through the sweat glands. So they should not indulge in cooking, and they should use a separate like utensils for their food also. If there is any pregnant women or children less than 5 years, it is better to stay in a separate room, and it should be followed for around 2 to 3 weeks. For pregnant age group women, we advise to not to have pregnancy for another 6 months. For reproductive age group males, also we advise pregnancy not to have pregnancy for another 4 to 6 months. So these are the precautions, and thank you.
Thanks, Dr. Harinandan. Such an elaborate presentation. And if there are any questions from the audience, them into chat box, and we can Dr. Harinandan for the next 10 minutes till the time is here. And thank you, Dr. Hari.
Yeah, thank you, Dr. Komal.
And so we'll move on to the next session, which is the case presentation. For the case presentation today, we have Dr. Rahul Kumar Shah. He's a resident in head neck surgical oncology at Kidwai Memorial Institute of Oncology, Bengaluru. And the case presentation topic is CA thyroid. For the examiners for today's case presentation are Dr. Arvind Krishnamurthy. Sir is professor in surgical oncology at Cancer Institute, Aguad, Chennai. Welcome, sir.
Thank you.
Next examiner we have is Dr. Richa Vaish. Madam is Professor Head Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Welcome, ma'am.
Thank you, Komal.
And third examiner is Dr. Kranti Kumar Gangiti. Sir is Consultant Head Neck Surgical Oncology at Continental Hospitals, Hyderabad. Welcome, sir. Dr. Kranti, I think Dr. Kranti has not yet joined in. So I'll try to contact him. In the meanwhile, Dr. Rahul, can you please share your screen? And with the permission of the examiners, we can start with the case presentation.
Yeah, please go ahead.
Hello. Hello, Komal ma'am.
Yes, Rahul, we can hear you. I think you can begin with the case.
Ma'am, slides are visible, ma'am. PPT.
Yes, they are.
Okay, ma'am. Okay, ma'am. Good evening, ma'am. Uh, so I'm presenting the case scenario of one patient. I examined this patient today only. So patient is a 73 years old male Muslim illiterate laborer residing at the Krishnagiri, Tamil Nadu, India. The patient presented to Department of Head and Neck Surgery, OPD, with a complaint of right side neck swelling since last 6 months. On elaborating the origin, duration, and progress, the patient was relatively all right 6 months back. Then he noticed the right side neck swelling since last 6 years. Sorry, yes, mistake. It is incidence in onset, gradually progressive from approximate 1 by 1 centimeter to present approximate 3 by 3 centimeter, largest in the lower neck and not associated with any pain. So patient is giving no any history of regarding the oral ulcer or problems related to any dentition, no complaint of throat pain, no complaint of difficulty in swallowing, no complaint of change in voice, no complaint of difficulty in breathing, no complaint of cough, no history of weight loss. Patient is giving a not any significant past history. Patient is not a known case of diabetes, hypertension, no past history suggests any TB, jaundice, blood transfusion, major surgery. Personal history is a patient taking an adequate diet with a good sleep and appetite, nutrition deficiency habit, with the addiction of the BD smoking more than 50 years, more than 10 pack years. Family history, treatment history, allergy history, drug history not significant pertaining to this patient. I have examined the patient on general examination. Patient is conscious, cooperative, well-oriented to time, place, and person. Patient is having a good performance status with well-built and nourishment. General examination, temperature is normal by oral, pulse 90 per minute, normal with normal rhythm, tension, force, and condition of all, blood pressure within the normal range. Respiration is normal without any pallor, icterus, cyanosis, clubbing, pedal edema, no generalized lymphadenopathy. So this is the clinical pictures of the patient. So local examination, I have examined neck. So there is a visible 3 by 3 centimeter swelling over the right side of the neck. Level 4, consistent with the level 4 with the normal overlying skin and surface. And one 2 by 2 centimeter bulge present over the right upper neck at the level 2, which is also with overlying skin normal. And one bulge over the 1 by 1 centimeter at the level of approximate level 3 lymph node level. It is also 1 by 1 centimeter with overlying skin normal. There is no scar, sinus, no other visible swelling visible. So I have palpated the case. So starting from the local examination of the neck, there is a 4 by 4 centimeter solitary swelling over the right side level 4 supraclavicular area, which is firm to hard in consistency, mobile, without fixation of the overlying skin. Similar swelling of 2 by 2 centimeter, mobile, present over the right level 2 area with overlying skin is normal, without any fixity to underlying structure and overlying structure. 3 by 3 centimeter swelling, palpable over the right level 3-4 junction area with overlying skin normal, without any fixity to overlying structure with normal mobility. All three swelling what I have palpated are firm to hard without any fixity to overlying structure and underlying structure. On palpating the central part of the neck, I have found 1 by 1 centimeter stony hard swelling over the right lobe of thyroid, which is moved with the deglutination without any finding suggestive of retrosternal extension. On left side of the neck, I have palpated a 4 by 4 centimeter left side level 4 swelling, which is without any fixity to overlying structure and underlying skin with firm to hard in consistency. Trachea position is central normal. I have not palpated any other visible pulsation, palpated any pulsations, other swellings. Trachea position is normal. Hello. So after basis of finding one nodule over the right lobe of thyroid, I have examined for history aspect for the history suggestive hypothyroidism and hyperthyroidism. So there was no any history consistent with the finding suggestive hyperthyroidism. Then I checked for the thyrotoxic features. I have not found any tremor or thrill or brute over any eye sign. Then I have examined for the laryngeal examination and bilateral vocal cords are mobile. systemic examination within the normal range. So I can summarize the case as a 73-year-old male with 6-month progressive multiple right side neck swelling with a incidental finding of left side neck swelling level 4 with solitary hard right lobe thyroid swelling moving with degglutination without any clinical invasive feature and with euthyroid status.
So Rahul, there is a swelling on both the sides of the neck, left and right, correct?
Ma'am, right, yes, ma'am, right 2, 3, 4, left 4 to 5 junction.
Yeah. So bilateral neck swelling.
Bilateral neck swelling, ma'am.
Yeah. So then, what differentials are you thinking of?
Ma'am, at the beginning of the history, because patient was not giving any history pertaining to thyroid midline swelling, so first my approach was I will rule out any upper aerodigestive tract malignancy at this age. So I rule out the starting from the oral cavity up to the pharynx, hypopharynx. So I have not found during my examination any mucosal abnormality. And pertaining to the lateral side of the neck, so my last DD was the thyroid also because I found the swelling palpable over the right lobe of thyroid, which is less than 1 centimeter, but consistent with the bilateral neck swelling, and lower leg swelling is possible with the thyroid.
Okay, let me rephrase the question. So if it is a bilateral lymphadenopathy, I want to know the differentials. Of course, if it is a locally advanced disease or any disease of the oral cavity will also called bilateral
Right.
lymphadenopathy. But
Yes.
apart from that, even if you have an early disease, because otherwise the patient was asymptomatic. So what are the sites
Okay.
you are thinking of?
Ma'am, upper side bilateral neck, ma'am, may be possible with ma'am nasopharynx, ma'am oropharynx midline lesion, ma'am with any hypopharynx larynx midline lesion can lesion approaching to midline can have bilateral neck metastasis.
Correct. So then what did you examine the nasopharynx, the
Yes, ma'am.
oropharynx?
Yes, ma'am. Yes, ma'am. I examined
You
the
did the
DNA
nasal
also.
test.
DNA
Yeah.
also. But
Okay.
patient was not given significant history, and right side lower neck is more involved. Left side upper neck is not involved. So even though I examined for nasopharynx also, but pertaining to the lower neck, I'm more going to the lower side of
Larynx, larynx
yes,
and
yes,
hypopharynx.
yes.
Okay, fine. So how will you investigate this patient? Dr. Arvind, you want to ask some questions?
No, I wanted to ask what is the, normally in exam you are asked for the first diagnosis. So what will you sort of, knowing the differentials is important, but then how you rate your differentials in the order of priority is also important. So in that case, Rahul, how do you mentioned all the things, but
Hmm.
what will be your first sort of, differential in this particular scenario?
Sir, 6 month duration, progressively age factors, the more than 70, and Indians continent, sir, with BD smoking addiction, going for the upper aerodigestive tract along with the thyroid also.
Any inflammatory lesions, Rahul? You can suspect some inflammatory lesions.
Sir,
pertaining to the subcontinent India. Yeah.
Sir, tuberculosis I can suspect, but sir, 6 months without any painful history, without any sir changes on that consistency in all these things, patient was not pertaining about the related to no cough, no fever history. So I have ruled out that part.
So your first diagnosis would be what you said?
Sir, before examination, I will consider as a upper aerodigestive tract malignancy, sir.
Yeah, obviously, even thyroid will be.
Yes, sir. Because pertaining age, I will consider as a bilateral neck, lower side more. So level may be, sir, larynx, hypopharynx, thyroid region.
Nasopharynx.
Nasopharynx, sir, left side upper neck is not involved. So
Okay.
I'm very less for nasopharynx, oropharynx.
So where all it's lower neck is predominantly involved, or
Yes, sir. Bilateral level 4, 5 junctions and level 2, 3, 4. So like a chain, right side level 2, 3, 4, and opposite side level 4.
what about infraclavicular primaries?
Sir, patient complaint of right side more, sir. Left side, if initial complaint was there, sir, I will consider for the abdominal malignancy, lung malignancy arising from the breast in female. But the right side, supraclavicular. So like that, I have differentiated the scenario.
Right. So it is a cancer only, right? you have any other non-malignant diagnosis you don't want to entertain at all?
Sir, non-malignant, sir, tuberculous lymphadenopathies can be possible, sir. But 6 months already without any changes happen in the lymph node status. So no abscess formation, nothing, no cough, no any symptoms of primary pulmonary TB. Can be possible, sir. Old age tuberculosis.
Can be lymphomas also, right?
Yes, sir. Yes, sir. Can be lymphoma, sir.
Yeah.
Can be,
Because
sir.
you have
Yes, sir. Yes, sir. Yeah, and
also one of the
it is.
important differential. I was actually asking, looking for that. You were
Okay,
mentioning upper aerodigestive, which is it's a generic term essentially.
Sorry,
It
I missed.
encompasses everything. So maybe I think that should also probably figure out in your list.
Yeah, lymphoma, sir. Okay, sir. I missed it. Okay.
Yeah, Richa, you was asking something. Go ahead.
Yeah. So, Rahul, how will you now investigate this patient? So, basically, this patient has bilateral lymphadenopathy and an incidental finding of a thyroid nodule. That is how you are putting it, no?
Yes, ma'am. Yes, ma'am.
Yeah. So, how will you investigate this patient?
Ma'am, first of all, ma'am, basic blood investigation with including of the thyroid function test, then followed by the ultrasonography of the neck with ultrasound guided FNAC of the primary lesion, and also from the neck lymph node, what I found means already patient complaining.
You don't know what's the primary, no?
Correct.
Sir. So I'm doing FNAC of both sides, sir. From a nodule, what I found also along with the USG, along with the FNAC from the neck node.
Right. You have the findings?
Sir, patient, new patient only, sir. FNAC finding I have, sir. Pre-op evaluation finding I have. FNAC and CT scan we have.
Can we share?
So, Rahul, yeah, kind of. I know that you have done the FNAC and you have the picture in mind, and it is a thyroid carcinoma, and that is why you are proceeding in that direction. But suppose this patient had just presented with a small thyroid nodule, which you are actually calling an incidental finding with bilateral lymphadenopathy. Any other imaging investigation, ultrasound is with such a lymphadenopathy. Okay, you want to begin with the ultrasound for the guided FNAC, maybe. But wouldn't you advise any cross-sectional imaging for this patient?
Ma'am, yes, ma'am. Cross-sectional imaging with CT MRI, ma'am. If I didn't found any primary site suspicious, then I can go proceed directly with the CT MRI or a FDG PET CT, if both can be possible. If I didn't found any finding on my examination.
So you will do the FNAC and wait for the finding of the FNAC and would not order the cross-sectional imaging till that time.
Cross-sectional imaging, ma'am, CT anyway in this case required, ma'am. Bulky nodal disease, lower neck involved. So anyway, USG followed by CT scan. CT scan supplement the USG finding. It's required in this case.
Is there any role of getting a serum thyroid globulin, Rahul, in this case, if you're looking it in this way?
Sir, pre-ops, sir, no, sir. FNA washout, I can, if diagnosis is not feasible with FNA cytological finding, then thyroglobin washout can be possible in the FNA aspirate of the lymph node. Otherwise, no relation to any pre-op thyroglobin measurement with it. A normal thyroid can secrete, sir. So advanced disease, it will be raised only.
Okay, so what are your FNA findings?
Ma'am, FNA finding, ma'am, from the thyroid nodule right side is category 6, ma'am, papillary thyroid carcinoma. And FNAC from the right side of level 4, it's metastatic papillary carcinoma thyroid.
So what will you do next?
Ma'am, cross-sectional imaging, CT scan to supplement my finding. Then based upon the consideration of all my clinical investigation radiological finding, I will classify the patient pre-op as a AGCC TNM classification. Based upon the lateral cervical lymphadenopathy bilateral, I will consider counsel the patient regarding the curative intent approach with total thyroidectomy with central compartment neck dissection with a bilateral lateral neck dissection level 2 to 5.
So your CT scan would be from which level to which level?
Ma'am, routinely we performed means CT neck with the upper part of the chest is involved. So I can show, ma'am. Ma'am, a CT scan, ma'am, DICOM visible, ma'am?
No, we just see your slides.
Slides, okay, okay.
If it's a different screen, maybe you'll have to
Yeah, yes, ma'am.
share that screen.
Yeah, yes. Well, ma'am, this is a contrast enhanced, ma'am, CT scan now visible, ma'am?
Yes, it is.
Yeah, so I'm scrolling down the CT scan. So from going up to down, I am finding one the lymph node or the right level 2 area with right level 3 2 junction. Then going down 3 also confluent with the above one. Plane with HCM is lost at some place with level 4 lymph node over the right side. And one calcified lesion over the right lobe of thyroid. So going from the left side. So again, left side, I'm finding lymph node at the 3 4 junction going down into level 4. So and so uppercut we have upper lobe and middle lobe up to. And we have advice for CT chest.
So when you have such bulky lymphadenopathy, you have advised a cross-sectional imaging. Apart from what you have already told us that he has bilateral lymphadenopathy and a thyroid nodule, what
Yeah.
are the other areas that you would like to focus, which you did mention while reporting the CT?
Ma'am, relation to the great vessels, ma'am. The ectopic site of the lymph node measurement, ma'am. Lymph node,
Like where?
retropharyngeal, ma'am. Here one node is a query, ma'am. And supremediacetum central compartment level 6 levels in lymph node. Here, ma'am, looks like one doubtful right side retropharyngeal lymph node. But size is yes, ma'am. Here, ma'am, I'm not sure it is a.
This is the level of the. This is where you see the retropharynx.
No, ma'am, it's above only level. But here something is it can be actually
Below the cricoid, isn't it a central compartment node?
Ma'am, too much posterior. Yes, ma'am, maybe paratracheal, maybe right.
Retropharyngeal will be higher up, no?
Higher, ma'am, medial to carotid.
So would you always go the contrast enhanced CT scan or would you do a plain CT scan? Because of course it's a locally advanced disease and you will have to give RAI to this patient.
Ma'am, contrast enhanced, ma'am. It will delineate the structure well. So it is helpful for surgery intervention.
But would it interfere with your RAI?
No, ma'am. Anyway, patient will take 4 to 6 weeks for that radioactive whatever means treatment therapy. Meanwhile, it will not means any significant difference if we do iodinated contrast or non-iodinated. So we can use because benefit of giving a contrast is more than risk involved with not giving a iodine.
Any other reason? Okay, fine, more benefit. But you said that you will take at least 4 weeks by the time patient comes for RAI. So does it really going to cause interference at that time? Any study or any evidence to support or refute?
No, ma'am, means our author means I can't quote study. Means I know, but at present I can't quote the perfect author name. Second is, ma'am,
Okay.
some area are not visible on US sonography, like supremediastinum, retropharyngeal. All this can be possible with and west means central compartment soft tissue involvement, like larynx, esophagus. The central structure is more able to delineate with CT scan.
Would you ever use any other cross-sectional imaging in these cases? Or it will always be a CT scan?
Ma'am, pre-op evaluation, ma'am, UC plus CT, it's enough, ma'am. MRI can be, but it's not usual. Ma'am.
If the disease is going deep in the TO groove, would you investigate it further? Or CT is good enough?
Ma'am, CT is good. It will show the extension in the tracheoesophageal groove. For soft tissue extension, if MRI do, it will be time taking, too much sequence. Patient will not be comfortable. So whatever imaging means benefit I'm getting from CT and USG, it is enough for pre-op evaluation.
Would CT be good enough to investigate for the esophageal involvement?
Ma'am, external mural transmural involvement and mural involvement. So externally, if it is involving, so we can give estimate about the esophageal invasion, but not as specific like MRI. So not as sensitive as MRI.
Any
Rahul,
other
you're,
investigation, Rahul?
Rahul, you're just thinking it in terms of cross-sectional images. Just think something else other
Yeah.
than cross-sectional imaging, because as Madam is given you a hint of thinking in terms of esophageal. So what else you need to investigate when you have a disease in tracheoesophageal groove?
Laryngeal vocal cord function, then the tracheoscopy, esophagoscopy means involvement inside is present or not.
That you will see on the CT scan also,
It
no?
is
Because you
also
have the cartilaginous framework,
cartilage,
so you have
yes.
film classification. Yeah. So you will come to know whether it is involving or not. The vocal cord, you have done the Hopkins anyway.
Hopkins and mobile.
Yeah, yeah. Does it make a difference if the esophagus is involved? So it's going to make a difference to your management plan?
Yes, ma'am. If I found a esophagus, I have to counsel patient. If mural only
Accordingly.
external only involvement, I can, as a say margin, I can remove that part. If it is involving
Yeah.
inside means transluminal, then it will depending upon the defect, reconstruction or primary closure, it will. I have to counsel the patient pre-op.
But CT is not a very good modality to assess a soft
Assess.
tissue. No? Yeah.
Yes,
So then
MRI can be that's soft tissue.
MRI can
So
be done.
any role of endoscopic ultrasonography?
Sir, we can do sir esophagoscopy, GI-scopy, sir, for transmural evaluation of both trachea and esophagus advanced case. But looking for CT, sir, it's not looks like it is going inside, and no symptoms also patient, no vocal cord palsy. So if little bit advanced disease I'm getting, then I will consider for the esophageal USG to look for the wall involvement.
what is the advantage of the transesophageal USG? Why are you using it? Now that we have led you there, you have agreed, but what is the advantage? So you can appreciate the layers of the esophagus and till what depth it is penetrated or involved. So you will
From
be,
outside
it gives you a precise evaluation
from
of the
outside to inside up to what layer.
Yeah, you can see the layers in the transesophageal ultrasound. Okay, in this case, it is not involved. So now what will you do with this? You have done the TFT, you have done the FNAC, you have established PTC, you have done a cross-sectional imaging. You have not done a chest CT, which you will do, you said, just to see the mediastinal nodes and metastasis. So now what will you do with this patient further?
Ma'am, curative into total thyroidectomy, center compartment neck dissection, bilateral neck level 2 to 5 clearance. After that, I will wait for his final outcome, histopath report.
Okay. Fine. So you have done it. You have got the same histology as papillary thyroid cancer with large bulky neck nodes.
Yes, ma'am.
Now what further? Arjun, sir, you also want to ask some question before he proceeds further?
No, I just wanted to know, are you aware of the layers of the esophagus?
Sir, 4 layers, sir. I mean, sir,
Ah.
mucosa, submucosa, then inner circular, outer longitudinal,
That's all. And
and
outermost.
adventitia outside.
Yeah. So there's no serosa of the esophagus. No, that's
Yes,
a
yes,
sort of thing.
yes, yes.
And this, and generally, have you like, how does the esophageal involvement actually occur? These tumors, they're locally advanced.
So first of all, sir, isolated esophageal involvement is very rare, sir. Basically, it's a laryngotracheal inversion followed by tracheal, followed by esophageal, according to the previous studies at all. And if it is involved, the main site culprit may be say tracheoesophageal groove, because there is a lack of barrier between the posterior tracheal wall, trachealis muscle, and adventitia of the esophagus. If this is reaching in there, then the chances that esophagus is only involved. But at that time, tracheal posterior wall is also involved. So both tracheal and esophagus can be possible as isolated. Otherwise, majority cases laryngotracheal junction, and as disease advance, it involves the trachea and esophagus.
Yeah, right. So it's generally rare to have a
Rare to have, sir. Very
full thickness involvement.
yes,
Generally,
yes.
all the
Majority transmural.
gets involved. So, and most of the times you can sort of get away with.
Yeah,
So,
yes, it is.
but of course, in this case, it's not. Yeah. Yeah, and your extent of the lymph node dissection, you said?
Sir, bilateral means bilateral right side, left side, the central compartment neck dissection with bilateral level 2 to 5.
2 to 5. Yeah. Does level 1 get involved?
Sir, level 1, sir, in case of 1B, if level 2 lymph node is extending to level 1B, and then very rare chance of less than 1% that level 1 can be involved. So in that case, if 1B is involved, so anyway, it's better to do 1A also. But in this case, 1B is not involved. Level 2 is involved. It is mobile and well away from the boundary of the 1B. So I will spare the bilateral 1B.
Right. Very rarely, no, there are some
Very,
isolated
sir, less
reports of
than means, post of
Yeah, very, very rare. Even if your 2 is slightly encroaching on 1B, that is not the 1B involvement. So 1A and 1B are
very less than.
usually never involved in.
Yeah.
Very, very, very rare.
Rahul, suppose if in your case scenario, if your thyroid FNAC suggests you have better
Yes, ma'am. So,
TT, no, not that way. Organize it, especially thinking thyroid also.
maybe your thyroid will be one of the DD if you think it in this way.
yes.
If
Ma'am,
the FNAC from the
thyroid
thyroid was not positive,
yes.
and you have the bilateral lymphadenopathy, which is a carcinoma, what is the clinical entity?
Ma'am, again, ma'am, metastatic cervical lymph node without any primary.
Correct. So how will you
Okay.
investigate this patient?
Ma'am, cross-sectional imaging, CT MRI or PET CT.
I know there are 3 cross-sectional imaging, my friend, but
Ma'am, PET CT scan, ma'am. Whole body PET CT, fluoride, 18 fluorodeoxy glucose, FDG PET CT whole body. I will consider.
So why are you thinking
Why?
so much, Rahul?
No, sir, I'm going towards that bachelor
No, because
three
I
that
think
more like
the
sorry.
scenario has changed. So I guess you're. So
Yeah,
that's
yeah.
what happens in the exam. No,
Yes, sir.
normally if it's a very classical case, of say bilateral lymph nodes and all those with positive FNA and also, then examiners normally they try to sort of tweak the scenario. So at that time you'll have to really regroup your thoughts and then sort of
Yes, sir.
uh, align your thoughts to the question asked. So there's a level 1 evidence, right?
Yes, it is.
Okay. And what else will you do? You'll ask for a PET CT and then
Sir, scenario is considered with the sir metastatic cervical lymphadenopathy with unknown primary. So PET CT followed by sir examination under anesthesia to look for the possible putative sign. Then based upon sir evidence, I will consider for the sir ipsilateral based upon the management of calcium unknown primary ipsilateral tonsillectomy tongue-based resection.
okay. No, I just want to know your
No.
FNA is good enough
Or you wanted to step up with something else apart from FNA? You told me list of investigations and panel. So
Yeah.
is it possible for us to get from all those things?
Sir, yes, sir. Yes, sir. FNA, we can, sir, FNA staining, sir, we can give to clue to sir origin from the sir abstent biomis nasopharynx and sir HPA positive oropharynx can be done, sir. So guidelines says that both can be done. So based upon that, putative primary site can be found based upon FNAC finding. Hello.
Yeah, we can hear.
So
Okay.
what will you do after your surgery? What safeguards will you take intraoperatively?
Yeah. Okay. Yes.
Now,
Agents will you use for surgery considering that?
Yes. Yes, sir. So, sir, sir, I will consider this case as a locally advanced disease, sir. So I will pre-off consider regarding the all possible complications related to surgery pertaining to this case, right side of recurrent laryngeal nerve and parathyroid glands. As I proceed to surgery, I will take proper precaution for preservation. If I am able to complete the surgery or with preservation of RLN, so outcome will be good, sir.
So this patient has bilateral bulky lymphadenopathy. So in all likelihood, this patient will have a central compartment node.
Yes, sir.
The thyroid is a small, no, let me complete. The thyroid is a small primary. Now, when you open the neck, you see it's studded with central compartment neck nodes, and the nodes are also encasing the nerve. Now, what will you do? It's not easy to find the plane around the nodes and really dissect it absolutely like it is. You find a plane and all, but that is not there because in this case, I'm anticipating a bulky
Yes,
nodes
ma'am.
and
Central.
central lymphadenopathy. And what will you do with the parathyroid? How will you identify,
Yes,
preserve? Any
ma'am.
precautions? Because you don't
Yes,
want a
ma'am.
central compartment recurrence, no?
Yes, ma'am. So basically, ma'am, this patient required bilateral central compartment level 6 lymph node dissection. So for that preservation of RLN, sir, I am not using the inferior approach or for RLN identification. I will identify the RLN at the entry point or otherwise at the lateral approach. Meanwhile, I can preserve the parathyroid superior also and the inferior also, mostly on the left side. Right side superior I can preserve with a superior approach and a lateral approach. And I have no facility for intraoperative nerve monitoring. We don't have. So I1M can be considered in this case for the right side of disease because it looks like it's disease encroaching totally toward the tracheoesophageal groove, entry point starting to the thoracic inlet going down both side, maybe possibility. So I1M will be helpful in this case.
If the node is stuck to the nerve, will you sacrifice a nerve?
No, ma'am. Pre-op vocal cord function is normal, so I will try to achieve the separation from the lymph node of the and the nerve. So if majority cases, it is possible to get away with a node only, and now is majority time can be preserved. I will consider for preservation of now because pre of focal cord function is normal.
Rahul, when do you want to use your inferior approach? Because you're saying that you don't want to use your inferior approach. So, what is the advantage and disadvantage of using the inferior approach?
Sir, basically, sir, inferior approach means uh, disease locally on the superior pole, middle lobe, not retrosternal extension, preservation of supralaryngeal nerve and supraparathyroid are more concerned. So with this approach, inferiorly thoracic inlet, I will identify the recurrent laryngeal nerve. So depending on the disease, sir, superior disease, inferior disease, this is just identification of RLN. So if retrosternal huge goiter, and now will be anchored to the undersurface of thyroid node, going inside the below the sternum. So in that case, inferior approach anyways are not possible.
How do you identify the recurrent laryngeal nerve with the superior approach? What landmarks you follow?
Ma'am, so, ma'am, superior pole, ma'am, after delineation of the superior pole, retraction of the thyroid upper lobe little bit medially with the laryngotracheal retraction, I am able to find the now at the laryngeal entry point, cricothyroid joint, otherwise inferior cornua of the superior thyroid cartilage. So this will be a consistent landmark. So at that point, I can able to identify the recurrent laryngeal nerve.
What is the disadvantage of this approach then?
Sir, I am identifying the now at the terminal point, sir. Maybe branch initially it will be there, so I'm not able to preserve that branch. So motor function maybe some will lost. I'm not sure it is a only branch or not. The branch may be possible. Then preservation of superior thyroid little bit disturbing the identify, and at this point, sir, bleeding chances will be more, sir, because posterior leaflet of the tubercle Beris ligament with vascularity it will hamper, and tubercle if is enlarged. So little bit technically demanding, sir.
So how many recurrent laryngeal nerves have you seen on one side?
Recurrent
Generally,
laryngeal
in your practice. So how many nerves can be there? Branching. How many branches of branching have you described?
yes, yes. Sir, before the entry point, sir, two branches can be possible, and extralaryngeal branches, if I consider, so sir, four branches can be possible if extralaryngeal happening. So at the level of ITS, a crossing, two branches can be possible, and distal part, sir, if extralaryngeal branches I will consider, so more four branches can be possible, sir. The recurrent, sir, non-recurrent, sir, it depends, sir. It's rare, so non-recurrent can be possible if branching pattern. I don't know about the non-recurrent branching pattern, but it can be possible.
Right. Anywhere between 2 to 6 or
Yeah.
even
2 to 6, ma'am. Yes, sir.
So if you have the terminal branching, which of the anterior or the posterior branch is motor? Usually.
Ma'am, anterior will be motor, more adductor fiber in anterior parts, ma'am.
What is the relation of the nerve with the tubercle?
Ma'am, it is posteromedial, ma'am. Tubercle encroach over the nerve, so now will go inside. So it will consider as a medially and posterior to tubercle.
So, if your Jucker candle is large, is there any relation with the nerve?
Sir, depending upon the tubercle
Any size?
yes, sir. It's a size criteria, sir, less than 0.5 to 1, more than 1, sir. So grade 1 to 3. So 2, I can lift the tubercle, I can found the nerve. 3, it will almost encroach the nerve, and now will go inside the medially. So it will depend upon the surgeon. I can dissect also, and if benign disease, it's depend upon surgeon, sir. It can leave little bit thyroid tissue there also. But malignancy, I will try to dissect.
say during your performance of the surgery, you have cut one nerve.
Yes, sir.
You find it after the end of the surgery.
Okay, sir. So, sir, is depend upon, sir, which side I am operated. If I cut the right side now and left side is preserved, sir, so then it's okay. So anyway, tumor infiltration will be there. So I can counsel the patient. One now palsy will be possibility in post-op. But in the opposite side, normal side, I have cut. Sir, basically, sir, it's better. So I will abandon my procedure. I abandon the procedure. I will not proceed to.
No, I'm okay. You'll abandon the procedure and then do what for the cut side?
Sir, cut side, sir. There are, sir. Cut, sir. So, sir, I can consider for the, sir, anastomosis of the primary neurorrhaphy, sir. So, answer cervical is of the same side, but in this case, maybe not possible because bulky disease. So, opposite side of ansa cervicalis, descending branch, I can do. Otherwise, primary direct connection with the muscle. Now, and I will put in the muscle only. So, this will give some chances of recovery. Hypoglossal.
Again, Rahul, you need to go in a stepwise fashion. Sir was asking you what if it was an sudden cut in the nerve. So you would try to do anastomosis or you wanted to do. So it has to be in a stepwise fashion, right?
Yes.
So
yes, yes. Sorry, sir.
it's a clean cut, right?
Clean cut.
And no segment loss. So now
Ma'am, primary neurorrhaphy can be considered, ma'am. Clean cut without segment loss.
Right.
And now can be a little bit segment is small. I can literalize the now from entry point little bit after elevation of the inferior constrictor. So that will give little bit length also.
You said that if you have cut it on the left side, you will abandon the procedure. Then what will we do further? You plan to wait. You are waiting for the recovery. Will it recover, or we will just let the patient be with the disease? What will we do?
Ma'am, left side through and through cut without segment loss neurorrhaphy. I will wait for 3 to 6 months for chances of recovery present or not. I will counsel the patient regarding the both aspect that if I go for another surgery after a observation period, after that chances of opposite side also with need for airway management required and considering the all clinical pathologic factor of the patient. So this will be the concise patient oriented double decision, ma'am. So both can be possible.
Are you expecting a recovery, complete recovery at 6 months?
No, ma'am. Minimum it will take if just stretched or just grade 1, then it will take 3 to 6 months. Maximum 1 year I can wait, but meanwhile patient disease will extend. So anyway, shared decision I have to take with patient and patient attendant.
So what is the extent of recovery you're expecting, Rahul, in this case? Suppose if you have a clean cut, so you feel that again the cords become mobile after 6 months or 1 year?
Sir, primary neurorrhaphy, sir, very rare chances, sir. It will recover, but during meanwhile, sir, benefit will be not too much gain because meanwhile patient disease is also will advance.
So how is waiting helping you?
What, ma'am?
How is waiting helping you then?
Ma'am, during meanwhile, ma'am, means neuronography can be considered. Myography means potential. All these things will required means recovery, confirmation of recovery. It is means I'm not recollecting the properly. If it is not giving any action potential means evoke potential, then there will no chances of recovery of the that repair I have done. So I will proceed for the opposite side surgery.
Electromyography, you are saying?
Yes, ma'am. Intraop can be considered, ma'am. Cricothyroid and.
But in this case, electromyography, I can understand if it is a chronic thing and you are looking at whether the nerve has degenerated. But this is a clean cut just now. How will it help? The end plates will be all okay.
No, ma'am. Means after observation, ma'am, I will cross check with
After 1 year.
No, ma'am. I most
6
probably
months.
I will wait 3 to 6 months. During meanwhile, so ma'am, I will.
What I want to understand is if you wait for 6 months, how will you take a call like now it's a time to go ahead with surgery? What thing are you waiting for at 6 months? How is waiting for 6 months helping you is what I want to ask.
Ma'am, if regeneration is there, then opposite side heavy disease is depending on the patient. Ma'am, patient is willing to do, then I will proceed for surgery. Ma'am, focal laryngoscopy examination I will see means it clinically recovering or not. Otherwise, no any another benefit. Ma'am. Just for patient concern only. Patient don't want any permanent airway management.
Now, if there is structural disease on the other side, that's what the question is. Why do you want to wait for 6 months? No?
Yes, yes.
What you are saying is little valid if it is a traction injury. There we are expecting a recovery. So maybe I can understand that there was a loss of signal and you thought of, coming
Yes,
back
ma'am.
and seeing again. In this case, it's a clear transaction. Like you have transacted the nerve.
Yes, ma'am. Transacted and repaired. So maybe I consider that. Maybe I will take my senior opinion also, ma'am. Two surgeon involvement I will consider. I will discuss. At this present, I am not able to manage. After this complication, I will discuss with my senior also what can be
Oh,
done. So I will discuss my thought process also. I will take some influence from there also.
okay. In this case, it's a small nodule, but if it was a large nodule, so how involvement of the trachea, how can you gauge and to what level to what extent the trachea is involved, and the types of resection or surgeries that you do if the trachea is involved? I mean, little theoretical question, but
Yes,
just
ma'am. Yes, ma'am. So, ma'am, first, ma'am, for tracheal invasion, ma'am, correlation of the papillary carcinoma with involvement of trachea to seen classified the type 1, type 2, type 3, type 4. So, type 1 may be, sir, just a extra perichondrium of the tracheal cartilage without disease going in between the cartilage or eroding the cartilage. Type 2 may be along with this eroding of the cartilage, disease little bit going in between the cartilage. Type 3 is all erodement with the lamina propria advancement. Type 4 plus type all three plus intramural means inside the tracheal lumen. This is for tracheal invasion. So based upon the clinical scenario, my option will be shave resection, then window resection, then sleeve can be considered with end-to-end reconstruction. And along with the esophagus, so no separate classification for esophagus and larynx only. But to consider the management protocol, so Derails classified the laryngotracheal invasion in the type 1 to 6 based upon the type of management reconstruction. So type 1 may be at the level of laryngotracheal junction. Vertical is less than 1 without involvement of a cartilage, means cricoid cartilage less than 1/3. Then length little bit increase, cricoid cartilage less than 1/3 only. Third is vertical length is more than 2 centimeter with involvement of the cartilage less than 1/3. From type 4, 5, and 6, the involvement of the cartilage, cricoid cartilage more than 50, and there is a vertical length is more than 2 centimeter involvement of the larynx picked up with esophagus. So based upon type 1, type 2, it will consider that you can go with just a shave resection, and based upon the pathology. Type 3, starting from 3, little bit tracheal reconstruction and resection required. Type 4, 5, 6, ultimately it will require the reconstruction of the laryngotracheal anatomy and esophagus also. So based upon the defect, lateral defect or circumference esophageal defect or larynx little defect or whole defect, the whole management will differ, ma'am.
what is the length of the trachea?
Ma'am, 10 to 15 centimeter, ma'am, in adult I can consider.
So how many rings can you sacrifice and still get away with the primary this end-to-end anastomosis?
Ma'am, maximum 6, ma'am. I want 10 rings below above the carina.
So you will send this patient for the radioactive iodine and you will give REI. How will you follow up this patient after that?
Yes, ma'am. Surgery done, ma'am. Radioiodine given. Then, ma'am, follow up will be, ma'am.
Sir, do we want, if we want to ask any questions, Kranti and sir?
Let's go ahead with this.
Ma'am, my follow up will be, ma'am, depending upon the response to therapy. So, thyroglobulin measurement, TSH measurement, clinical examination, and USG. So, based upon that, whatever finding I will get in this scenario, I will modify the risk stratification and the response to therapy. Accordingly, I will follow the patient for rest of the duration with thyroxine suppression.
Would you consider EBRT in this case?
Ma'am, EBRT as a primary role, ma'am, without surgery.
No. In as an adjunct to the REI, not as a only. adjuvant treatment?
H1 treatment.
So RA definitely you will give,
Yes, ma'am.
because it's a well differentiated. Yeah, it's a papillary thyroid cancer.
So,
Would you ever consider EPRT in these cases?
ma'am, it's depend upon the completion of resection, ma'am, because T4A disease, ma'am, if gross residual disease is there, so according to AHNS, I can consider EBRT role. And if microscopic disease, so this is no role of EBRT, means already T4A disease. For T4B disease, I will consider EBRT.
And what is the evidence to support?
Ma'am, in T4A disease, ma'am, two scenario will be there, ma'am. Gross residual disease. So according to American Head and Neck Society and Mayo Clinic, ma'am, MD Anderson data, ma'am. So in this case, they have utilized the BRT along after radioiodine therapy. So they have got benefit in MD Anderson. Is more than 100, so they can valid option for gross residual disease after T4A. And same series from the T4A after my microscopic disease, residual disease. So they have not found any significant benefit. So in this case, American Head and Neck Society, they are considering no need to give EBRT. Radioiodine will take care of this type of disease.
Check for any questions from anybody in the group.
None from my side, sir. I think we can wind up.
Yeah.
Do we want to give him the feedback?
Yes, ma'am, please. Yes, ma'am, I request all the three examiners to give him a score out of 10 because he's exam going, so it'll help him improve in his preparation.
Richa, why don't you start? Because
I would give him probably around 7.5 out of 10. And my feedback would be that even if you have a straightforward case, if there is a twist and the examiners are leading you some different directions, stay focused, and examiners do modify the case scenarios. So
Thank you, ma'am.
Yeah, Rahul, actually, you're very well read with the theory. As madam said, basically, you need to just focus on your this presence of mind during that particular scenarios and all. That's it. Otherwise, it
Thank
went
you, sir.
well.
Thank you, sir.
All the best for your exams.
Thank you, sir.
yeah, I also agree with both of you. I think you're good. And the thing is that you are telling all the answers, like for example, we ask imaging, you say everything. So try to sort of focus or give a one precise answer if the option exists. So I
Okay.
think that will sort of create a better impression. As said, like you've read well, and so you know the theory. It's just that sometimes in practicals they just check how your approach or philosophy, broad philosophy of management, and also I think focus more on the evidences. No? So all those
Right.
things are important. Whenever they are asking for evidences, you should be able to quote at least a couple of important. Some you were able to, some you would not. You were not. But I guess try to sort of focus, know a little bit of the for evidences, and that will really help you sort of score much higher marks. That's what,
Yes.
and
Thank you,
maybe
sir.
go for the gold medal or something. All the best to you.
Yes, sir. Thank you, sir. Yes.
I think with this, we'll wind up the session. And I express my sincere gratitude to all the examiners. Arvind sir, thank you so much for joining in. Richa ma'am and Dr. Kranti sir. And thank you, Dr. Rahul, for the case
Yes, thank you,
presentation.
ma'am. Thank you, ma'am. Thank you so much, ma'am.
Thank you to all the participants who joined in with us. The next session will be after 15 days after 15 days Thursday. Thank you so much, everyone.
thank
Yeah, thank you, Komal.
Yeah, thanks, Komal.
Good evening, everyone.
Recording stopped.